Welcome to Endometriosis Voices, listening to lived experiences, learning from science. This is the second of a two-part video that we are using to unpack the myth that pregnancy cures endometriosis. If you've seen the first part already, you will remember that we mentioned that indeed there were some evidence about some pregnant women having pain relief during pregnancy and sometimes during breastfeeding. In the second part, we are going to look at the science that explains why some of these pregnant women have pain relief and why it doesn't last beyond a year or two postpartum. If you are watching this video while you are trying to conceive, if you've had fertility treatment, or you've decided not to pursue pregnancy, this topic can be a little bit tender. Nothing in this video is a judgment on your choices or your journey. In the second part, we will look at what science actually tells us about estrogen, pregnancy, and endometriosis. Why some people feel better when they are pregnant, and why those changes usually don't last beyond 2 or 3 years postpartum. We will also talk about why suggesting pregnancy as treatment can be deeply painful, especially when endometriosis itself can make pregnancy difficult to achieve. If you have done any form of reading about endometriosis, you might have already come across endometriosis as estrogen-dependent disease. That means estrogen tends to feed the growth and activity of endometriosis lesions. Researchers have found that endometriosis tissue can respond strongly to estrogen through its receptors. But some lesions do not actually just respond to estrogen that is produced by the follicles. They can produce estrogen locally by using an enzyme called aromatase, almost like a tiny hormone factory that exists inside the lesion itself. In simple terms, this means that when estrogen levels are high and unopposed, lesion can stay active and inflamed. When estrogen is suppressed or when progesterone dominates, lesion often becomes quieter. This science is the same principle used in many endometriosis treatments today. Hormonal medicines such as certain pills and other suppressive therapies lower estrogen activity and/or increases progesterone-like effect to calm down the lesion and reduce pain. Pregnancy also changes the hormone trajectory, but in a very specific and temporary way. Let us bundle this together. Imagine endometriosis as a small campfire that is fed by estrogen. In most of the month, the fire is burning. Sometimes it's burning slowly, in other times it is flaring. Hormonal treatment try to take away fuel or dampen the flames. Look at pregnancy as something that rearranges the weather around the fire for a while. There is less monthly wind from periods and more rain from progesterone activity, except that the weather does not remove the wood and there is still amber underneath. In this case, if the weather becomes favorable again, liken it to after pregnancy, then weather conditions can turn back in a way that favors lesion and the amber begins to flare and flames again. Important to the scenario that we just went through is the endometrial maturation and the hormones that regulate this physiological process and how these processes interrupted during pregnancy. Let's have a look at it. If we are looking at a typical 28-day menstrual cycle, then day 1 to day 5 would represent the menstruation phase, and this marks the beginning of the menstrual cycle. During this stage, estrogen and progesterone levels are at their lowest. Up to day 14 is what we call the follicular phase. Even though we say day 6 to day 14 represent follicular phase, it sort of overlaps with the menstrual phase. This is because the hormone which stimulates the follicle to start maturing or releasing some eggs starts producing from about day 1, but reaches a level that is enough to trickle the ovaries to release an egg roughly from around day 6. And this is what happens. This hormone, follicle stimulating hormone, is released from the brain, and then it stimulates the ovaries to release about 10 to 15 eggs. Around the same time as these eggs begin to develop, they produce estrogen up until about day 14. By roughly day 7 to day 10, one of the eggs among the 10 to 15 that was initially released becomes the dominant one, and this is what we call a Graafian follicle. On day 14, a hormone we call luteinizing hormone increases or sharply peaks and causes the Graafian follicle to rupture. Look at this like having an egg that you finally break down to prepare whether your omelette or whatever meal that you want to do. Except in this case, you don't throw away the shell. So the shell becomes what we call a corpus luteum. And the corpus luteum exists or stays active from day 15 to day 28, which is what we call the luteal phase. What the corpus luteum does is that it produces progesterone. And so progesterone levels begins to rise from day 15 and remains higher up until day 28. And what it does is that it tells the body to maintain blood vessels and tissues in the endometrium, waiting for possible fertilized egg to come and then attach itself and implant. However, if fertilization does not occur, the corpus luteum begins to disintegrate, and for that matter, the levels of progesterone concentration reduces significantly. Because this progesterone is the one that was holding on to the endometrial lining that has matured, waiting for implantation, the endometrial lining also begins to disintegrate and then falls out as the menstrual blood. Just about the same time, a signal is sent back to the brain that, oh wait, this month we couldn't conceive, and so could you help us begin to mature another set of eggs? And then follicle stimulating hormone releases and the cycle goes on like that. I'm open to doing an entire episode that explains in details how this cycle is maintained and regulated if it is requested. It is logical to ask, what then happens if there is conception? If there is conception, then the chain of command that sends a signal to the brain to produce more follicle stimulating hormone, to stimulate the follicles to produce or release eggs that will produce estrogen, is shut off. Once that chain of command is shut off, the corpus luteum remains active and continues to produce progesterone to maintain the endometrium and the pregnancy for the first 7 to 10 weeks of pregnancy. Just about that same time, placenta would have been formed. And once the placenta forms, it thanks the corpus luteum and takes over the role of progesterone production to maintain the endometrium and, for that matter, sustains the pregnancy. Other tissues such as the adrenal gland helps in the production of progesterone, but their role are very limited, and so we will not go into it. Another important concept you may have come across if you have been reading about endometriosis is that endometriosis is an inflammation-related disease. Inflammation is also the immune system's first defensive mechanism to harmful substances like pathogens and damaged or damaging tissues. In this case, endometriotic lesions, which is a deposition of tissues in areas where it's not supposed to be, becomes an irritant and also a damaged tissue. However, the endometriotic lesion has managed to develop a mechanism that takes advantage of the inflammation response mechanism to its advantage instead of being overwhelmed by it. In pregnancy, however, the maternal immune system shifts to allow the body to carry the baby to term, which can also reduce some inflammation in other areas, and in this case, in endometriotic lesion. So look at endometriotic lesion as an automobile. The estrogen is the fuel, and inflammation lays an asphalt on the road ahead of the automobile. During pregnancy, estrogen concentration is significantly reduced, and then the maternal immune system is physiologically suppressed to allow the baby to grow to term. When done right, low levels of estrogen, which means we don't have enough fuel for our automobile, and then reduce activity of inflammation. Now we can lay asphalt ahead of the automobile, means that the automobile would not be able to work as we want it to work. And this is the mechanism that exists behind pain relief during pregnancy. Several studies show that many women with endometriosis report less pain during pregnancy and in the month just after birth. One study followed about 130 women with endometriosis. Most of them experienced relief during pregnancy and shortly after delivery. However, 2 years after giving birth, 84% of these women reported that they have experienced at least one episode of moderate to severe pain, and a third of them needed medical or surgical treatment for recurrence. It is understandable if this feels heavy, especially if you were told that pregnancy will fix anything. In my opinion, having an accurate information can also protect you from false promises. The fact that the pain relief experienced during pregnancy is only temporary is not the only reason why it is not advisable to offer pregnancy as treatment and or cure for endometriosis, but also because though we know endometriosis does not always cause infertility, endometriosis is one of the common reasons why people struggle to conceive. Studies estimate that between 25 to 50% of women who are infertile have endometriosis, and roughly about 40% of women with endometriosis experience infertility. If 10% more do not want children, then in 1 of every 2 endometriosis sufferers you recommend to get pregnant so that they can have some pain relief, which is temporary, cannot either get pregnant or do not want to get pregnant at all. Therefore, statements such as, "Have you tried just relaxing and getting pregnant? It will help your endometriosis." Or, "Why don't you hurry up and have a baby before your endometriosis gets worse?" For someone who has been trying for months or years, possibly going through several cycles of in vitro fertilization processes, pregnancy loss, or financial and physical strain, these words can land like a punch. They are not simply bad advice. They touch the deepest fears and grief around parenthood, identity, and the future. For those women who do not want to have children, being told to use pregnancy as a treatment can feel like their body is being framed only in terms of reproduction rather than their own well-being, and by implication, it was irresponsible of them to choose not to have children in the first place. Picture a woman in her early 30s. She has had 3 unsuccessful cycles of IVF due to severe endometriosis. She is physically exhausted, her finances and savings are drained, and she's grieving every negative test that she gets. At a family gathering, if one of her relatives say, "Maybe you should just get pregnant, your pain will go away." In this statement, there may be no bad feelings, but the impact is very profound. To such an individual, she may hear, "You are not trying hard enough, and your pain is probably your fault because you are not getting pregnant." However, the science tells us this is not the truth, and emotionally, it is a heavy burden to carry. But even if pregnancy cures endometriosis, the idea that someone has to become pregnant in order to access relief raises serious ethical and emotional questions. Some key points to note. Healthcare aims to support people in making informed choices that fit their lives, their values, and their risks. Therefore, no one should feel they must undergo a major life event that has permanent responsibilities and possible medical risks just to manage a chronic disease. Many people with endometriosis do want to have children. However, they may not be able to carry pregnancy safely at this time or are not ready for parenthood at this stage. Your pain deserves treatment whether or not you decide to have children. Your values as a person is not measured by fertility, pregnancy status, or parenthood status. For anyone living with endometriosis and thinking about pregnancy, now or in the future, here are some practical takeaways drawn from research and management guidelines. 1. Talk to a specialist. If pregnancy is a goal, an endometriosis-aware gynecologist or fertility specialist can help plan timing, surgery decisions, and treatment around your priorities. Know that you have options. Depending on your situation, these options might include surgery, different hormonal medicines before trying to conceive, or even assisted reproductive technologies like IVF. 3. Plan for after pregnancy. Because symptoms often return, having a follow-up plan for pain and disease management after birth can reduce anxiety. Seek emotional support. Studies show that women with endometriosis and infertility together have higher levels of depression and anxiety and lower quality of life. Psychological support, peer groups, or counseling can make a real difference. And remember, if you choose not to pursue pregnancy or you decide to stop treatment, that decision is valid. Your worth is not a test result or a birth certificate. You deserve care that respects your pain, your hopes, your limits, and your choice about pregnancy and parenthood. Thank you for spending time here. If you feel safe to share, you are welcome to leave a comment about how advice around pregnancy has affected you, whether you have children, want them, are unsure, or have chosen a different path. Your story might gently correct a myth and help someone else feel less alone. Subscribe and share the page with someone who you think might benefit from its content. Endometriosis Voices, listening to lived experiences, learning from science.